Good day, everyone. So today we'll be having the last lecture to complete your respiratory physiology module. Before I start, I would like to thank Dr. Trinidad for sharing his slides, which I have used to complete my lecture. So the roadmap for today's lecture will be to differentiate pulmonary and systemic circulation, to explain vascular control mechanism that affect your pulmonary blood flow, the Starling's forces that would affect pulmonary blood flow, and formation of pulmonary edema. Differentiate the lung zones in a normal upright lung. Apply ventilation-perfusion relationship and the compensatory mechanisms for VQ mismatching. The control of ventilation, and discuss the given scenarios with alteration in your PO2 and PCO2. To start with, differentiating pulmonary and systemic circulation, let's look at the circulatory system. So, this is the whole entire circulatory system. So, the pulmonary circulation begins at the main pulmonary artery, and this side, the blue line here, which receives your mixed venous blood. So this is this goes to the terminal bronchioles, which this artery then branches and accompany the airways as far as your terminal bronchioles, and beyond that they break up to supply the capillary beds that lies in the walls of your alveoli. This is where oxygenation takes place. Oxygenated blood is then collected from the capillary bed and form from the smaller veins, and eventually forming your pulmonary vein and drains to the left atrium. Okay, so this circulation appears to be a simple, smaller version of your systemic circulation. Your systemic circulation starts with the aorta and ends in the right atrium. In contrast to your systemic circulation, the pulmonary circulation is a low pressure, low resistance, and a high compliance system. Let's take a look at the difference between the pulmonary circulation and your systemic circulation. Look at the mean pressure in your pulmonary artery, which is about 14. In the aorta, the mean pressure is 90, which is about 6 times more than the pulmonary artery. The pressure in the right and the left are not very dissimilar, about 3 and 8 respectively. Thus, the pressure difference from inlet to outlet of the pulmonary artery and your systemic system are about 14 minus 8 is equal to 6, and 90 minus 3 is equal to 7. So both circulation have the same blood flow value since they are in series, but the pulmonary vessels are wider and do not show the thick muscular coats as do systemic vessels. Remember, the pulmonary circulation serves only the lungs. So this function in the pulmonary circulation is primarily for blood oxygenation and CO2 elimination, while your systemic circulation, the blood flow goes to the different tissues. Your vascular resistance, remember that in the pulmonary circulation you have a low vascular resistance, and in the systemic circulation you have a higher vascular resistance to drive blood or to propel blood to the different parts of the body. So the pressure inside the pulmonary circulation is low, and you have a high pressure in your systemic circulation. How about response to hypoxia? Pulmonary circulation has a very unique response to hypoxia. They vasoconstrict in response to hypoxia. However, in your systemic circulation, you have vasodilation. How about compliance of the vessel? You have a very high compliance in your pulmonary circulation, while a low compliance in your systemic circulation. Okay. So next will be to discuss the vascular control mechanism that affect your pulmonary blood flow and your Starling's forces that affect your pulmonary blood flow and its acceleration or formation in pulmonary edema. Okay, remember that hypoxia is very important in the control of your vessels in the pulmonary circulation. So there would be hypoxic vasoconstriction, which occurs in your arterioles in response to a decrease in low oxygen tension. So this is your local response, which may be present if there is hypoxia affecting less than 20% of the blood vessels. In high altitude, because in high altitude there would be low inspired oxygen tension, and they will have a greater effect on your pulmonary vascular resistance because all vessels will be affected. Okay, what are the factors and hormones that regulate pulmonary blood flow? You have pulmonary vasoconstrictors. So these are the factors that may cause vasoconstriction. Pulmonary vasodilators. So these are the factors and hormones that may cause vasodilation. So take a look at oxygen tension. It is a potent pulmonary vasoconstrictor. Okay, let's try to review the concept of your transmural difference. Transmural for distensible compressible vessels, the transmural difference is the difference between the pressure inside the vessel minus the pressure outside the vessel is equal to your transmural difference. Okay, so what is the importance of this? The greater the transmural difference, the greater is the vessel diameter, the lesser would be the resistance. Okay. In the pulmonary, in the lungs, there are two types of vessels that are seen here. Okay, you have your extraalveolar vessel outside your alveolus and your alveolar vessels in between your alveoli. Okay, so this alveolar capillaries is affected by your alveolar pressure, while your extraalveolar vessels is affected by your pleural pressure. So these alveolar vessels are sensitive to changes in your alveolar pressure, but not to changes in your pleural or interstitial pressure. So what happens? How does this affect your vascular resistance? Okay, looking at this graph wherein you have your residual volume to FRC and to TLC. On the y-axis, you would note your pulmonary vascular resistance. Okay, so this graph will show the effects of changes in the vital capacity on the total pulmonary vascular resistance contributed by your alveolar and your extra-alveolar vessels. To clearly illustrate this relationship, we have another graph to show the relationship between your alveolar vessels and your extra-alveolar vessels. Okay, so in your alveolar vessels at residual volume, your pulmonary vascular resistance is low. But as you inhale to total lung capacity, because of increasing alveolar pressure, what happens to the vessel? If you inhale to total lung capacity, the alveoli will expand, causing lengthening of your alveolar capillaries, and the diameter narrows. So, the pressure inside your pulmonary vascular resistance will increase in your alveolar vessels. Let's take a look at your extra-alveolar vessels. So, from RV, your extra-alveolar vessels has a higher pulmonary vascular resistance. As you inhale to total lung capacity, okay, there would be pulling effect. More interpleural pressure increases to from RV, FRC to TLC. There would be pulling of your extra-alveolar vessels, causing the diameter to increase. So, the pulmonary vascular resistance from RV to FRC to TLC decreases. If you combine these two resistance, you will get your total pulmonary vascular resistance. So from RV, you will have a U-shape pulmonary vascular resistance from RV to FRC to TLC, wherein at FRC, you have the lowest pulmonary vascular resistance. Remember, this is where you have your tidal breathing, right? So, at TLC, the alveolar vessels contribute much to your total vascular resistance compared with your extra alveolar vessels. Okay, so let's look at the question. Based on the graph, can you answer at total lung capacity the pulmonary vascular resistance of your alveolar vessels, extra-alveolar vessels? So which is higher at total lung capacity? You can type in your answers in the chat box. While the total pulmonary vascular resistance at FRC and TLC. So based on the graph, you would note that the alveolar vessels has a higher pulmonary vascular resistance at TLC. So the answer here is A. While the total pulmonary vascular resistance at FRC and TLC, so the total here, total pulmonary vascular resistance is this line here. So you would note that at TLC you have a higher total pulmonary vascular resistance, so the answer here is B. So remember, resistance is equal to the length and viscosity. If you lengthen the blood vessel, you increase your resistance. While if increasing the viscosity of blood, you also increase the resistance. While decreasing the radius, you also increase the resistance. Okay. So, what are the factors that may influence your pulmonary vascular resistance? So So you have your passive and active influences in your affecting your pulmonary vascular resistance. So I think this is included in your handouts, so you must read the different passive influences on the effect of your pulmonary vascular resistance. So increased lung volume, again from the graph, it will increase your pulmonary vascular resistance. Why? Because there is lengthening and compression of your alveolar vessels. Decreased lung volume below FRC, there would be compression of and less traction of your extraalveolar vessels. In increasing pulmonary artery pressure, increased left atrial pressure or increased blood volume, increased cardiac output, your pulmonary vascular resistance decreases. Why? Because of recruitment and distension. Gravity has also an effect on your pulmonary vascular resistance, decreases in gravity-dependent regions of the lung. Okay, hydrostatic effects leads to recruitment and distension, and increase or more positive interstitial pressure increases your PVR because of compression of your vessels. Increased viscosity increases PVR. Viscosity directly increases resistance. Positive pressure ventilation, increased alveolar pressure increases your PVR because of compression and de-recruitment of your alveolar vessels. Positive intrapleural pressure increases your PVR because of compression of your extraalveolar vessels, and compression of your vena cava decreases pulmonary blood flow and leads to the recruitment. Okay, these are the active influences of your pulmonary vascular resistance. So, increased pulmonary vascular resistance is seen when you stimulate your sympathetic innervation, the giving of norepinephrine and epinephrine alpha adrenergic agonists, your prostaglandin, thromboxane, endothelin, angiotensin, histamine, alveolar hypoxia, alveolar hypercapnia, a low pH of your mixed venous blood. Okay. So, there are medications or important drugs in the treatment of pulmonary arterial hypertension. So when you have increased vascular resistance, you may have pulmonary arterial hypertension. So you can give your endothelin 1 antagonist that can relax or decrease your pulmonary vascular resistance. So example of your endothelin 1 antagonist is your bosentan. Okay. During exercise, this graph will show the effect of blood flow on your pulmonary vascular resistance. So increased blood flow during exercise will decrease your pulmonary vascular resistance. So what will be the mechanism involved to decrease this pulmonary vascular resistance in response to your elevated blood flow and perfusion pressure? You have your recruitment and distension. So you can recruit other capillaries that are not yet used and distend your capillaries. In doing so, you can decrease your pulmonary vascular resistance in response to your elevated blood flow and perfusion pressure. Alright, so let's try to review what we have discussed from the past few minutes. So you have two types of vessels. Your alveolar vessels are exposed to your alveolar pressure and are compressed if lung volume increases, resulting to an increase in resistance. Remember, resistance is directly, your length of the tube is directly proportional to resistance. while radius is indirectly proportional to your resistance. Extraalveolar vessels are affected by elastic pull of the surrounding lung parenchyma, so the greater the lung elastance, the greater the vessel radius, the lower is the resistance. Pulmonary vascular resistance is usually lowest at FRC and increases at higher and lower lung volumes, creating a U-shaped graph from RV to FRC to TLC. So let's move on to your Starling's forces that affect your pulmonary blood flow and its acceleration or formation in pulmonary edema. Let's try to review the different forces involved in your Starling's equation. So you have your hydrostatic pressure, which pushes fluid. So when you talk about capillary hydrostatic pressure, water goes out of your capillaries. So when you talk about interstitial hydrostatic pressure, water moves from the interstitium to the capillaries. Okay, another force is your oncotic pressure. So when you talk about capillary oncotic pressure, it pulls the fluid from the interstitial space to the intravascular or capillaries. So when you talk about interstitial oncotic pressure, it pulls water or fluid out of the capillaries. So if there is a derangement of either of these factors, there would be fluid formation in the interstitial space. So just remember that a positive flux favors fluid accumulation in the interstitium, while a negative value favors reabsorption. Whatever fluid that remains in the interstitium is being taken care of by your lymphatic system. Alright, so fluid that gets out into the interstitium will be taken care of by the lymphatics. So if there are derangement of in the different, like increasing capillary hydrostatic pressure or decreased plasma oncotic pressure, there would be fluid formation or accumulation resulting to pulmonary edema. So they will first accumulate in the interstitium before flooding the alveoli. So this is a normal X-ray. You would observe that this is hyperlucent. Okay, so what do you observe in this X-ray on the right? There are infiltrates, no? Yung white na yan. So that would represent fluid in the interstitial spaces. Okay, what are the factors that predispose a patient to develop pulmonary edema? So, if there are derangement in the factor in your Starling's equation, primarily increased capillary permeability. So, when do you see them? If you have acute respiratory distress syndrome, oxygen toxicity, inhaled or circulating toxin. So, another factor in your Starling's equation would be increased capillary hydrostatic pressure. So, capillary hydrostatic pressure will push the fluid to your interstitium. Okay? So, hydrostatic pressure increases, pushing the fluid to the interstitial space. This can be found in your patients with increased left atrial pressure resulting from left ventricular infarction or mitral stenosis. Okay, if you have a decreased interstitial hydrostatic pressure, like in instances wherein you have a rapid evacuation of pneumothorax or hemothorax, or in patients with upper airway obstruction, that may result to a decreased interstitial hydrostatic pressure. Decreased colloid osmotic pressure, like in patients with kwashiorkor or protein starvation. So because the albumin, no, in the blood is not enough to hold the fluid, so decreased colloid osmotic pressure will push the fluid to your interstitial spaces. Dilution of blood proteins by intravenous solution, or renal problems resulting in urine protein loss, proteinuria, like in patients with nephrotic syndrome. Other etiologies would be problems in the lymphatic drainage. We mentioned that any fluid that goes to the interstitial spaces will be taken care of by your lymphatic system. So if there is problems in the lymphatic drainage, secondary to tumors, interstitial fibrosis diseases, or other conditions, this may lead to effusion. Unknown etiology, like other conditions that may lead to pulmonary edema when you're exposed to high altitude pulmonary edema, or pulmonary edema after a head injury or drug overdose. Okay, so remember, fluid movement across the capillary endothelium is governed by your Starling's forces. Any fluid that makes its way into the pulmonary interstitium must be removed by your lymphatic drainage. Okay, let's now move on to your lung zones. So we will discuss the different lung zones in a normal upright lung. Okay, so normally you have three lung zones. Your zone 1, okay, your zone 2, and your zone 3. So this is at the level of the heart, okay, middle portion. So this model explains why there is an even distribution of blood flow in the lungs according to the pressure affecting the capillaries. So to clearly illustrate, no? So in this figure, you would see the alveolus, okay? The alveolus, here it's clearly seen that it is very big, no? So remember, the alveolar pressure is not affected by gravity. It's the same whether it's located in the apex or at the base. Okay, however, your arterial pressure and venous pressure is affected by gravity. So, as you increase on leaving the pulmonary artery, so blood must travel against gravity to the apex of the lung in an upright position. So for every 1 cm increase in location of your pulmonary artery segment above the heart, there is a corresponding decrease in the hydrostatic pressure equivalent to 0.74 millimeters mercury. So the pressure in the pulmonary segment, artery segment, that is 10 cm above the level of the heart is 11.4 millimeters less than the pressure in a segment at the level of the heart. So conversely, when the pulmonary segment is 5 cm below the heart, it has a 3.7 millimeters increase in the pulmonary artery pressure. So the effect of gravity on blood flow affects the arteries and veins equally and result in a wide variation in the arterial and venous pressure from the apex to the base of the lung. So let's take the different zone. Zone 1, at the apex, you would note that your alveolar pressure is greater than the arterial pressure and greater than the venous pressure. So the capillaries here in zone 1 are collapsed because of the greater alveolar pressure, and blood flow ceases. So this is seen in conditions with low lung volume, severe hemorrhage. So positive patients who are hooked to a positive pressure ventilation. So again, normally you don't see zone 1 unless you have a patient suffering from severe hemorrhage or low volume, or the patient is hooked to a positive pressure ventilation creating a high alveolar pressure. Zone 2. Okay. PA or arterial pressure is greater than your alveolar pressure, which in turn is greater than your venous pressure. Okay, because PA or alveolar pressure is greater than your venous pressure, so the greater external alveolar pressure partially collapses the capillaries near their venous venous side, so creating a damming effect, no? Referred to as your waterfall effect. Okay, zone 3, your PA is greater than your venous pressure, which is greater than your alveolar pressure, and blood flows in this area in accordance to your pressure gradient. So the pulmonary blood flow is greater in the base of the lung because of the increased transmural pressure that distends the vessels, and they have a lower resistance. So how do you memorize this? So just take a look at the position of your alveolar pressure. At zone 1, where does your alveolar pressure located? So it's in the first letter. At zone 2, it is in the second, no? Gitna. At zone 3, your alveolar pressure is on the third. Okay? So zone 1, alveolar pressure is greater than arterial pressure, greater than venous pressure. In zone 3, arterial pressure is greater than alveolar pressure, greater than venous pressure. So zone 3, zone 1, zone 2, zone 3. Zone 3, arterial pressure is greater than your venous pressure, greater than your alveolar pressure. Okay. So we'll now go to your ventilation perfusion relationship and discuss the compensatory reflexes or VQ mismatching. So let's just take a break. Alright, so let's continue. So we'll now discuss ventilation perfusion relationship. Okay. So before we discuss ventilation perfusion relationships, let's try to analyze this graph. So this graph will show on the x-axis the location or the apex of the lung. This is the lungs, apex or the top of the lungs, at the bottom or the base of the lung. There are two parameters here. So we will discuss the distribution of your ventilation and perfusion from the apex to the base. All right. So, looking at this graph, so from the apex to the base, because of gravity, there is a greater blood flow at the base compared with the apex. Okay. Because of gravity, the alveoli at the apex are more distended. Okay, there would be a greater transmural pressure in the apex. That's why the alveoli in this normal upright lung is greater or distended compared with the base. So there is better ventilation at the bottom or at the base compared with the apex. Okay, so you are looking at two parameters, ventilation and perfusion. So ventilation and perfusion. So ventilation and perfusion. So you can see, now this is the middle portion wherein you have a ventilation, perfusion that meets in the middle, or a ventilation perfusion of 1. So in the x-axis, you have here your position in the lungs from apex to base. On the y-axis, you have your alveolar ventilation or perfusion per unit lung volume. On the other side, you have your VQ or your ventilation perfusion ratio. So ideally, a VQ of 1 is present in a normal situation wherein ventilation is matched with the perfusion. Okay, so because of gravity, blood flow increases by 8 times more compared with ventilation from the apex to the base, while ventilation only increases 3 times greater from the apex to the base. Okay, so at the apex, okay, what can you say about your ventilation and perfusion ratio? So ventilation is greater than perfusion. So at the apex, you have a high VQ. Okay, the middle portion, this is the ideal VQ. You will find the ideal VQ relationship. While at the base, wherein ventilation is lower than perfusion, so therefore if you try to compute for the VQ ratio, you have a low VQ. Okay. So, again, at the apex or at the top of the lungs or the upper lung zone, you have a high VQ. And the middle portion, this is where you find a VQ of 1. At the base or at the lower lung zone, you have your low VQ because perfusion is greater than ventilation. Okay, so this is a simplified lung model. So this will represent a one respiratory unit and another respiratory unit. So this is your pulmonary artery, which supplies blood, and there would be gas exchange at this level. Okay, and then drains to your pulmonary vein. So there should be matching of your ventilation with the perfusion to have a VQ of 1. So if there are no problems, if your ventilation and perfusion matches, your capillary oxygen tension at the end capillary level will also match with the oxygen tension present in your alveoli. Okay, so let's make this lung model simpler. Okay, this slide is taken from Dr. Tim Trinidad's lecture long time ago. So, for example, if the minute ventilation is 6 liters per minute, okay, let me write that, 6 liters per minute ventilation. Okay, so you are receiving 6 liters of air for gas exchange, and this will be distributed evenly to one respiratory unit. So that's let me change the, okay, so 3 liters from the right side, 3 liters, and another 3 liters will go on the left respiratory unit. How about the perfusion? Your cardiac output or perfusion is equal to 6 liters per minute. Okay, so we are receiving 6 liters of ventilation and also receiving 6 liters per minute. So pulmonary artery will distribute this 6 liters of blood. So at 3 liters will go to the right, 3 liters will go to the left. So ventilation and perfusion should equal, no? In order for gas exchange between the alveolar gas and your pulmonary capillary blood. So there is optimal gas exchange. So this is what you term as your ideal VQ relationship. So you have to match whatever amount of gas present in the respiratory unit with the blood flow in your pulmonary artery. Okay, so ventilation of 3 against a perfusion of 3 is equal to 1. So this is your ideal VQ, a VQ of 1. Okay, so these are the different types of your ventilation perfusion relationship. So this is in the middle portion is your ideal VQ. Okay, if there are problems or conditions that may result to low ventilation, such as increased airway resistance or low compliance or a foreign body obstructing the airway, this may result to a low VQ or a shunt VQ. So there are problems in the ventilation. Instead of receiving 3 liters, this respiratory unit only received 2 liters of gas. So ventilation 2/3 is lesser than 1. So you have a low VQ. If you have a total obstruction, such as an intrinsic mass occupying the airway, or a foreign body obstruction, no, which totally occludes the airway of this respiratory unit, so you will not receive any ventilation or gas. So your ventilation in this respiratory unit is 0/3 perfusion. So this is a VQ of 0, or your shunt VQ. Okay, let's move on to the other condition. When you have problems in the perfusion, partially occluding the blood supply or the perfusion that goes to your capillaries. So therefore, your perfusion, instead of receiving 3 liters of blood, you only receive 2 liters of blood. So there's no problem with ventilation. Still, you receive 3 liters of air for gas exchange. So 3/2 is greater than 1. So you have a high VQ, or a VQ of greater than 1. So this exists when you have a low perfusion relative to its ventilation. So if you totally occlude the perfusion, so you have a 0 perfusion in this respiratory unit, but ventilation is not affected. So ventilation of 3 in this respiratory unit over 0 is equal to your infinity. Okay, so VQ, a high VQ, and infinity, that affects your perfusion. Okay, what are the causes of these VQ abnormalities? Again, we mentioned if there is high airway resistance. What conditions can lead to high airway resistance? Patients with asthma or COPD, no, that could lead to a low ventilation, so causing a low shunt. 2/3 is lesser than 1. Or in the presence of low compliance, such as in conditions like your pulmonary fibrosis or scoliosis, so that can lead also to a low VQ. So low VQ, 2/3, lesser than 1. Okay, how about shunt VQ? Okay, if you have a total airway obstruction, such as in cases of foreign body, we have seen a lot of cases with foreign body, so they can lead to a shunt VQ or a 0 VQ. Intrinsic airway mass, totally occluding the airway, leading to the respiratory unit. So there would be 0 ventilation, but the perfusion is not affected. So you have a ventilation perfusion ratio of 0. Atelectasis, that can compress your alveoli, like in conditions like having hydrothorax, fluid inside the thorax, or air, pneumothorax, inside your pleural space. Passive atelectasis seen in the absence of surfactant, like in hyaline membrane disease. Okay, ARDS. Alveolar flooding, like in patients with congestion or pneumonia. They can totally occlude the airway, the alveoli, and cause a shunt or a 0 VQ. Okay, what are the causes of a high VQ or infinity? So, perfusion, partial obstruction of your pulmonary vessels, such as seen in your pulmonary embolism, or in low hypotensive states, hypovolemic shock wherein the perfusion is affected. So that can cause a high VQ. When there is complete obstruction of your pulmonary vessels, such as also in your pulmonary embolisms that completely obstruct your perfusion. So your perfusion here is 0. 3/0 is a VQ of infinity, while 3/2 is a VQ of greater than 1. Okay, so let's discuss what would be the relative ventilation of the different types of ventilation perfusion problems. So this is the ideal again setup wherein you have 3 liters of gas over 3 liters of cardiac output or perfusion. So you have a VQ of 1. Okay, in low VQ or shunt VQ, wherein ventilation will be less compared with perfusion. So if the ventilation is less compared with perfusion, you have a relative hypoventilation. So there is a ventilation problem here. So 2/3 causing a low VQ, 0/3 causing a shunt or a 0 VQ. This may result to a relative hypoventilation. On the other hand, when you have perfusion problems obstructing the perfusion, so ventilation is not affected. So 3/2 is greater than 1. 3/0 is equal to infinity. You have a relative hyperventilation. Okay, reviewing what in your Respi 1, what are the factors that would affect your oxygen tension and CO2. Remember that ventilation, all right, when you increase ventilation, you increase the oxygen tension and decrease your CO2 tension. So ventilation, wherein gas exchange occurs, oxygen gets in, CO2 gets out. So if you increase your alveolar ventilation, when you increase your alveolar ventilation, you increase your oxygen tension, you decrease your CO2 tension. However, in patients with VQ mismatching, when you decrease your alveolar ventilation, okay, when there is a problem with your alveolar ventilation, so there would be a low oxygen tension and a high CO2 tension. Okay. So what would be the consequences of VQ relationship with regards to your oxygen and CO2 tension? Remember what we have discussed? So in an ideal setup, your oxygen tension is about 104 millimeters mercury. Your CO2 tension is about 40 millimeters mercury. In a low and shunt VQ, okay, low VQ and a shunt VQ, there is relative hypoventilation. Okay, so when you have decreased ventilation, your oxygen tension would tend to be lower than your ideal oxygen tension. So it could be lower than 104, while your CO2 tension would be higher than 40. Okay, because there is relative hypoventilation. Okay, in high VQ and VQ of infinity, there is relative hyperventilation. Okay, so that is why the oxygen tension and CO2 tension are high and low. No? So, hyperventilation, you increase your oxygen tension greater than 104. Your CO2 tension decreases lesser than 40. Okay. So, let's try to define a shunt. A shunt is a condition wherein blood was not allowed to have gas exchange with your alveolar alveolar gas. So what are the types of shunt? You have your anatomic shunt and your alveolar shunt. So you have your anatomic shunt and your alveolar shunt. So there are two types of alveolar shunt. Your true alveolar shunt here and your shunt alveolar shunt effect. Okay. So true alveolar shunt, again, 3 liters of blood is not given a chance for gas exchange because there are 3 liters of blood here, but the respiratory unit in this area has no ventilation. So this is your true alveolar shunt. In this area, wherein you have 3 liters of blood and there's 2 liters of gas, there is 1 liter of blood that is not given a chance for gas exchange. So this is your alveolar shunt effect. Okay. Remember your VQ relationship in a normal upright lung. So you will find that in the lower lung zone, wherein you have a low VQ, you normally have the alveolar shunt effect that you can find in the lower lung zone. Okay. So the total physiologic shunt comprises your anatomic and your alveolar shunt, your true alveolar shunt and your alveolar shunt effect. Okay, the total physiologic shunt comprises 4% of the left cardiac output. However, in pathologic states, wherein you have increased shunts, like in lung diseases that may create a low or a zero VQ, in cardiovascular diseases that can have passage of blood from right to left heart without oxygenation, like in congenital heart diseases, you will have an increased shunt that may increase your total physiologic shunts. Okay, let's move on to your ventilation, dead space ventilation. How do you define dead space? So this is where air does not participate in gas exchange. So dead space volume is the portion of inhaled gas that does not participate in gas exchange, and dead space ventilation is the volume of air that is distributed to the dead space per unit time. Okay, you have your anatomic dead space and your alveolar dead space. Okay, you have your anatomic dead space, which can be found in the upper airway and your conducting zone up to your terminal bronchioles. Once you have your respiratory bronchioles, it is now considered as your respiratory zone. So, hindi nakasama yon. Okay, you have your alveolar dead space that can be found in a high or infinity VQ. Okay, so when you have a high VQ, so 3 liters of air and you have only 2 liters of blood, So 1 liter of air is not given a chance for gas exchange. So you call this your alveolar dead space. So in VQ of infinity, you have 3 liters of air which is not given a chance for gas exchange because of complete obstruction. So this is also your alveolar dead space. In a normal upright lung, you can find, no? So in upper lung zone, you have a high VQ. So you can have, normally, you can find your alveolar dead space. Okay. So, normally, dead space volume is around 150 ml in a normal 70 kilogram body weight individual, or 2 ml of the actual body weight in kilograms. So anatomic dead space is found in the upper airway and your conducting zone, while your alveolar dead space can be found normally in the upper lung zones. Okay, in pathologic conditions, when you have increased alveolar dead space, such as seen in pulmonary embolism and hypotensive states, can increase your dead space. Okay, so keep in mind that all the respiratory units are connected to each other. Okay, so ideally, no? So this is your ideal setup. So you have a VQ of equal to 0. So ventilation is 3, perfusion is 3. Ventilation perfusion ratio is equal to 0. In shunt or low VQ produce a shunt effect. So ventilation is a problem. Okay, what happens here? In the respiratory unit wherein you have problems in your ventilation, okay, instead of receiving 3 liters of gas, so because of the problem, obstruction, this respiratory unit receive 2 liters. So ventilation 2/3 is lesser than 1. So where did the 1 liter of gas went? So the 1 liter of gas will go to the other respiratory unit. So this respiratory unit will receive 4 liters. So 4/3 is greater than 1. Okay, how about this respiratory unit? So ventilation, instead of receiving 3 liters, because of the complete obstruction, this respiratory unit only has 0. Wala, 0. So where will the 3 liters of gas move? So it will be diverted to the other respiratory unit. So this respiratory unit will receive 6 liters of gas. So 6/3 is greater than 1. So in shunt VQ or low VQ, it indirectly gives to a high VQ or dead space. On the other hand, if you have a high VQ, okay, or a VQ of infinity, where there is a perfusion problem here, okay, so ventilation is not a problem. Both respiratory units are receiving 3 liters. Okay, so if the cardiac output is also 6 liters per minute, because of the perfusion problem in one side, so this capillary only receive 2 liters of blood. The other liter will go to the other side. So instead of going all the 3 liters on the right, the 1 liter of blood will be diverted to the left side. So in this respiratory unit, ventilation of 3, perfusion of 2 will have a VQ of greater than 1. While in this respiratory unit, you have a ventilation of 3, perfusion of 4, a VQ of lesser than 1. Okay, in complete obstruction, okay, the 6 liters of blood, because of the complete obstruction, will go to the other side. So you have 6 liters going to the left, 0 on the right. So 3 over 0 is equal to a VQ of infinity. Okay? While on the other respiratory unit, you have a 3 over 6 is lesser than 1. So, high or infinity VQ or dead space will indirectly give rise to a low VQ. Okay, so what will be the consequences of your VQ mismatching? So, in normal conditions, you can find your anatomic dead space and your alveolar dead space, which is found in the upper lung zone. However, in pathological states wherein you have VQ mismatching, which directly or indirectly cause a high infinity, this may add to your alveolar dead space. Okay? So that would increase your dead space ventilation, affecting your alveolar ventilation, causing a lower oxygen tension. So again, so instead of increasing your dead space ventilation, will lower, okay, your alveolar ventilation, decreasing your oxygen tension, and increasing your CO2 tension. Okay. So, again, so increasing your dead space ventilation will decrease your alveolar ventilation. Again, reviewing the relationship of your alveolar ventilation will cause a decrease in oxygen tension, hypoxemia, and increasing your CO2 tension, causing hypercapnia. Okay, what will be the compensatory mechanism for a primary low VQ or a VQ of 0? Okay, so this will again be your ideal setting wherein your VQ is equal to 1. Okay, if there are ventilation problems, so ventilation, you have a low ventilation on one side and a higher ventilation on the other side. Okay, what will be the response of your lungs? So, there would be hypoxic vasoconstriction. So, when you have ventilation problems, remember, you have hypoxia. Okay, the response, remember, hypoxic vasoconstriction. When you have the local response to hypoxia would be vasoconstriction. So, instead of receiving 3 liters of blood on one side, this side wherein you have your ventilation problem will receive only 2.5 liters of blood. This will partially correct your VQ mismatching. So the other side will receive a higher blood that is supposed to go to this side. So this side, the left side, will receive 3.5. No? So this will partially correct your VQ mismatching. So there would be vasoconstriction when you have ventilation problems. How about a high VQ or a VQ of infinity? So this again the ideal setup, a VQ of 1. So if you have problems with perfusion, okay, so you have a VQ of greater than 1, what will be the response? There would be bronchoconstriction. Okay, instead of receiving 3 liters of gas, so this respiratory unit which has your perfusion problem will receive 2.5 liters, and the other 0.5 liters will go to the other respiratory unit, so partially correcting your VQ mismatching. Okay, so remember, if the primary abnormality is your ventilation, there would be vasoconstriction. If the primary abnormality is your perfusion, there would be bronchoconstriction. So the rule of thumb, the other component will compensate. So ventilation, there would be vasoconstriction, so perfusion will compensate. No? Perfusion. There would be vasoconstriction. While if the problem is perfusion, there would be bronchoconstriction, so ventilation. So the other one will compensate. Again, to review your ventilation perfusion relationship. At the apex, you have a high VQ. When you have a high VQ, your oxygen tension is increased compared with the base of the lung, which has a low VQ. So a low VQ, high VQ, so greater than 1, lesser than 1. So if you have a low VQ, your oxygen tension is less. And your CO2 tension is high at the base, while your CO2 tension at the apex is less. Okay, so this summarizes the regional differences in ventilation perfusion ratio. So as you can see, alveolar ventilation is greater at the base, and so with perfusion. No? So ventilation is greater at the base and perfusion, but perfusion is 8 times greater at the base compared with ventilation. Okay, so when you try to compute for your VQ ratio, you have a greater VQ ratio at the apex compared with the base. So if you have a higher VQ at the apex, your oxygen tension tends to be higher compared with the base. And your CO2 tension, CO2 tension is greater at the base compared with the apex. Okay? So there. If you try to plot the different regions of the lung, so at the apex you have a higher VQ. As you go down to the base, you will have a low VQ. So x-axis will represent the oxygen tension, while your y-axis will represent your CO2 tension. So at the apex, you have a higher oxygen tension but a lower CO2 tension, while at the base, you have a higher CO2 tension compared with your oxygen tension. Okay, let's try to answer this VQ relationship. So if VQ increases, so VQ increases, okay, what will happen to the delivery of oxygen relative to its removal? the delivery of oxygen relative to its removal will increase. True or false? Type in your answer in the chat box. How about the removal of CO2 increases relative to its delivery? Alright. So, and alveolar PO2 decreases. How about the alveolar PCO2 decreases when you have VQ, increased VQ? Okay. So, I'll give you 1 minute to answer the question. So, you have to type in 4 letters for the first question, second question, third question, and fourth question. Okay, so the answer is true. The delivery of oxygen relative to its removal will increase. In high VQ, okay, there would be the oxygen will increase. Okay, the removal of CO2 increases relative to its delivery. So high VQ, hyperventilation, the removal of CO2 increases. So when you increase your ventilation, you remove your CO2. So what will happen to your alveolar oxygen tension? If you increase your VQ, your oxygen tension increases. So the answer here is false. Your alveolar PCO2 decreases. The answer is correct. Okay, so let's try to review. Ventilation perfusion ratio determines gas exchange. So you have to match, no, perfusion, ventilation, and perfusion at the alveolar capillary level. So the ideal VQ ratio is close to 1. Okay, some books will tell you 0.8 to 1.2. And this will affect your oxygen tension and CO2 tension. If the ventilation perfusion ratio is 1, your oxygen tension at the end capillary will be similar to your alveolar oxygen tension of 104. And your PCO2 tension is 40. Okay, so this summarizes, no? This table summarizes all the relationship of the different types of your VQ to oxygen and CO2 tension. So ideally, this is the ideal, a VQ of 1. So you have a normal relative ventilation to perfusion. Match sila, 3/3. So your oxygen tension normally is 104 and your CO2 tension is 40. When you have a high VQ, okay, high VQ in patients with hypotensive state, okay, this is usually found in the upper lung zone. You have a relatively high ventilation compared to perfusion, so your oxygen tension will increase higher than 104. Your CO2 tension will decrease lower than 40. In patients with high VQ of infinity, such as in pulmonary embolism with complete obstruction, you have a more higher relative ventilation to perfusion, a relatively higher oxygen tension, and a relatively lower CO2 tension. Okay, in patients with a low VQ, such as in cases of asthma, so you have a lower relative ventilation to perfusion. So when you have a lower ventilation or hypoventilation, you have a lower oxygen tension and a high CO2 tension. When you have a VQ of 0, okay, you have a greater lower ventilation relative to your perfusion, a lower oxygen tension, more relative or more lower oxygen tension, and a greater increase in your CO2 tension. Okay, so let's now move on to the last topic on control of ventilation. Okay, these are the four major sites of ventilatory control. Your respiratory control center, which is found in your medulla and pons. Your central chemoreceptors, your peripheral chemoreceptors, and your pulmonary mechanoreceptors or sensory nerves. Your pulmonary receptors, mechanoreceptors may be found in your airway. Okay, so you have your, in this illustration, you have your brainstem. So this is where your medulla and pons, wherein this is where your nuclei responsible for generating your inspiratory and expiratory neurons, no? So you have your DRG, your nuclei, DRG, dorsal respiratory group, and your VRG, your ventral respiratory group. Okay, your dorsal respiratory group consists mainly of inspiratory neurons responsible for driving your diaphragm. They are initially, no, responsible for or integrating the different cardiopulmonary reflexes that affect your respiratory system. Okay, so you have your VRG, your ventral respiratory group, which consists both the inspiratory and expiratory neurons. So this group drives either the spinal respiratory neurons innervating mainly the intercostal and abdominal muscles innervated by your vagus nerve. So you have two distinct nuclei which is present in your medulla. So these two nuclei are responsible for the generation of your respiratory pattern or ventilatory pattern. Okay, so this figure will give you the patterns of breathing patterns of respiration if you transect the pons or medulla at different levels. So this figure will illustrate the effects of transection at the different levels. So this is labeled 1, 2, 3, and 4. So if the brainstem is transected immediately caudal to the inferior colliculus at this level, so labeled 1, the breathing pattern shows an essentially normal balance between inspiration and expiration. No? So even if the vagus nerve are transected, so you have seemingly a normal inspiratory and expiratory pattern. At the level of the pons, no? If the brainstem is transected in the pons, level 2. So the breathing pattern, level 1, level 2. Okay, the breathing pattern can cause apneusis or a prolonged pause, no? If the vagus nerves has also been transected. Okay, so there's a pause, interrupted or interruption. So apneustic breathing consists of prolonged inspiratory efforts interrupted by occasional expiration. So this is at the level 2. Okay, when you transect at level 3, a pattern of inspiration and expiration is maintained, although you may observe that this may seem to be irregular pattern, even if all the other afferents to this area, including the vagus, are also severe. No, there would be the breathing pattern may show also a period of apneusis. Okay, so there would be a prolonged inspiratory pause interrupted by occasional expiration. Of course, if you transect at the level of, so level 4, at the level of the medulla, no, between your DRG and VRG, okay, so there would be no breathing, so you will not have respiration, rather than the patient would have to have a respiratory support. Okay, so this is your central chemoreceptor, which is present in your brain. Okay, so a chemoreceptor is a receptor that responds to a change in the chemical composition of the blood surrounding it. Okay, so you have your arterial blood here. Your blood-brain barrier will not allow the hydrogen to get in. Okay, so your bicarbonate can slowly get in, but it takes hours. So what is more sensitive is your CO2 changes. So your CO2, the changes in your CO2 will stimulate your chemoreceptor to function. So these are specialized cells in the ventrolateral surface of the medulla, which are responsive or sensitive to the pH of the surrounding extracellular fluid, and this is in contact with the CSF surrounding it. So remember that the blood-brain barrier is permeable to CO2 but not to hydrogen, and the bicarbonate and CO2 that is produced in the cells of your brain as a product of your metabolism, no, is can increase the PCO2 in your CSF, no, a few millimeters higher than the arterial blood, so that the pH is slightly more acidic than the plasma. So changes in the arterial PCO2 by altering the pH activate the homeostatic mechanism that can return the pH back to normal. So the blood-brain barrier regulates the pH of your CSF by adjusting the ionic composition and bicarbonate of your CSF. So these changes in the CSF bicarbonate occurs slowly, whereas changes in the CSF PCO2 can occur within minutes. Thus, compensation for changes in the pH of the CSF requires hours to fully develop. Okay, you have your peripheral chemoreceptors. So these peripheral chemoreceptors can be found in your carotid and your aortic bodies. Okay, they respond well to changes in your arterial oxygen tension and PCO2 tension and pH. So it is the only chemoreceptor that respond to changes in oxygen. Okay, how about your pulmonary mechanoreceptors? We mentioned that these are found in the smooth muscle of your large and smaller airways. Okay, so they can be found in the pulmonary vessels. Okay, they respond to stretch. Okay, so you have the stimulus here, your reflex name, your Herring-Brewer inflation reflex that respond to a stimulus. So the stretch receptors within the smooth muscle of your large and smaller airways can cause a cessation of your inspiratory effort. Okay? So you have your lung deflation, Herring-Brewer deflation reflex, possibly the J receptors or irritant receptors in the lung through the vagus nerve, causing respiratory hyperpnea. Okay, so you have your mechanoreceptors that can also affect, no, the pattern of respiration. Okay, so this figure summarizes the control of respiration. So what are the three stimuli? An increase in the PCO2 level can stimulate both the peripheral chemoreceptors and your central chemoreceptors, which are found in the medulla. Hypoxemia can cause or can stimulate your peripheral chemoreceptor. Acidosis or a low pH can stimulate your peripheral chemoreceptors. So all these factors can stimulate your peripheral chemoreceptors. Okay, so once your peripheral chemoreceptors and your central chemoreceptors are stimulated, they will send signals to your central pattern generator, which is found in your medulla and pons. This will send signals, no, through the spinal cord that will send efferent fibers to the muscles of your respiration, which is particularly your diaphragm and the chest wall and other conducting airways. That will result to increased ventilation. So increased ventilation would increase your oxygen tension, would lower your PCO2 tension, and normalize your pH. Okay, so the higher centers can also stimulate the spinal cord, causing to increase the muscles of your respiration and increase ventilation. Okay, so what will be the effect of hypoxia and hypercapnia on ventilation? Remember, hypoxia and hypoxia can increase ventilation, and hypercapnia can also increase ventilation. So in the presence of the two, hypoxia, when you have a low oxygen tension, in the presence of higher CO2 levels, it accelerates or increase your ventilation. Okay, so the sensitivity of your PAC, the levels of your PaCO2 increases in the presence of hypoxia. Even in the small increase of your PaCO2 in the presence of hypoxia, your ventilation increases. Alright, so that ends up our respiratory 3 lecture, and let's try to review all the concepts. Again, pulmonary circulation has a low pressure, low resistance, high compliance compared with systemic circulation. Alveolar vessels are exposed to alveolar pressure and are compressed if lung volume increases, resulting to increased pulmonary vascular resistance. Extraalveolar vessels are affected by elastic pull of the surrounding lung parenchyma. The greater the lung elastance, the greater will be the vessel radius. The lower is the resistance. Blood flow is unevenly distributed in the upright lung. There is higher blood flow at the base than the apex as a result of gravity. Hypoxic pulmonary vasoconstriction reduces the blood flow to poorly ventilated regions of the lung. Fluid movement across the capillary endothelium is governed by your Starling's forces. Ventilation perfusion ratio determines gas exchange in any single unit. Ventilation perfusion ratio close to 1 results in oxygen tension of approximately 100 or 104 and PCO2 close to 40. VQ greater than 1 increases oxygen tension and decrease PCO2 tension. VQ lesser than 1 decrease oxygen tension and increase PCO2 tension. A cycle of inspiration and expiration is automatically generated by neurons in the medulla. The peripheral chemoreceptors respond to changes in your arterial oxygen tension, PCO2, and pH, while the central chemoreceptors respond to changes in the CSF PCO2 and pH. So learning from home can be difficult, but it's definitely achievable. So remote learning helps reinforce lifelong skills such as time and energy management, independence, and creative thinking. We miss going to class and see our students face to face, but we have to adapt to the new classroom, the new normal. We also miss this kind of students. All right. So, we have to adapt to the new classroom, the new normal, through the use of Blackboard, Zoom, Google Meet, and other platforms. So, stay safe, stay at home, stay healthy.